Dr.
Well, Arvind. Today, this is our 36th peculiar case renal transplant meet we conduct every first Saturday. Without just a paucity of time, I restrict myself to very salient points which are pertaining to both speakers and panelists so that we can allow more time for discussion. So first, we have two interesting presentations today, one by Dr. Rogan, another by Dr. Gauri Shankar. The first case by Dr. Rogan, I read about his one slide he sent to me probably that I just want to give the introduction about this topic. I mean, his presentation is we had a global outbreak of COVID-19 that has left a deep and lasting impact in our society, the far-reaching consequences that are difficult to capture in mere words. The ignition of virus and subsequent vulnerability of the human body to many opportunistic pathogens today is going to talk about mucor particularly. In case of immune frailty has led to unprecedented ordeal for individuals across the world. So today, the hidden threat, unmasking a post-COVID odyssey. Dr. Rogan's own journey and experience in combating the effect of post-COVID-19 on this particular patient present a very narrative, and that will be both harrowing and inspiring. So, 1 minute, just. Take minutes, sir. I have a dark disconnection.
You're audible.
No, nothing, sir. Voice is audible, sir?
Yeah, very well audible.
Oh, sorry, sir. Okay. So today, Rogan's, just to give a brief introduction, Rogan's academic journey, I read his resume. It was quite interesting. It was characterized by his exceptional undergraduate training, distinguished postgraduate achievements, and impactful professional experience, which exemplifies his potential as a professional nephrologist as of now. As an accomplished author and dedicated researcher and insightful educator, Rogan is poised to share a compelling case study today that will not only illuminate the complexity of nephrology, but also showcase the innovative treatment approaches he has adeptly adopted. So listening to his odyssey is sure to provide a profound understanding of steadfast approach to such a difficult to treat patients. So following which we have Gauri Shankar, is under the guidance of renowned Dr. Sambat Kumar in South and Madurai. He is a progeny from SGPJ Chandigarh. His journey so far has been nothing short of remarkable, and he is shining a lot in the initial 4 months. I think he joined in Meenakshi Mission Hospital just 5 months ago. Currently, a part of his esteemed team at Madurai Meenakshi Mission, he has taken up his nephrology practice from day one like duck to water. His remarkable his remarks, I could see his remarks and replies in our group discussion peculiar cases, which evidently showed his in-depth knowledge and understanding, especially he navigates through complex medical phenomena like a seasoned nephrologist. I think he deserves a lot of appreciation for that. In his upcoming presentation today, he's going to delve into a particularly very intricate subject, unraveling post-transplant podocytopathy, challenges in diagnosis and care. So his presentation will offer valuable insight and promise to enhance our understanding. We eagerly anticipate Gauri Shankar's presentation today and look forward to gaining new perspective and knowledge from in the subsequent discussion we have from our panelists too. So it is with a great anticipation and respect that we announce the esteemed panelists of our upcoming event today. Both panelists are distinguished nephrologists renowned for their expertise in the field of kidney transplant. Their vast knowledge and experience have earned them a reputation as a ready reference guide to many people here in down south. One such luminary figure is Dr. Humble yet incredibly knowledgeable teacher from Coimbatore. He is a founder and of Coimbatore Kidney Center in Coimbatore. Sir is practicing there for almost 4 decades, whose presence today will undoubtedly enrich our discussions. Sir is unparalleled in his clinical approach. He has taught many students in his life, and he has seen ups and downs in transplant patients, and he knows in and out of many issues which is happening in the transplant immediate post-operative in the long run. Sir, we are happy to have you here, sir.
Thank you.
An extraordinary physician, an astute clinician I admire a lot. She's from Madam from Salem Kaveri Hospital. She's HOD and medical director. She will play an adjuvant role to Dr. Kesar to make the discussion useful to everyone. So without delay, I call upon Dr. Rogan to share his slide to start his presentation. Rogan?
Yeah, thank you, Dr. Vel.
Yes, sir.
Is the slide visible to you?
Yeah, very much, very much. Your voice is very clear. You can make it a slideshow.
Yeah. So good evening, everyone. A big thank you, Dr. Vel, for those very kind words. A big thank you to Dr. Rajan also for calling me and extending this invite. And it's really humbling to be there at such a wonderful podium with such eminent nephrologists across the country. So a big thank you one and all. And without much ado, I get into this talk. So the title of my talk is A Hidden Threat, Unmasking a Post-COVID Medical Odyssey. The story goes back in 2021. This is a 49-year-old techie. He was working in Bangalore, but his native is of Orissa. He had no prior medical history, no diabetes, no hypertension. And during the year 2021, he was working out of home. So he was in his hometown, Orissa. And he presents in April of 2021 with a viral prodromal illness, which then progresses to severe acute respiratory illness. And he was admitted to Amri Hospital at Orissa. He was found to have COVID-19 with a CT severity score of around 11 by 25. So he was admitted there. He was oxygen dependent. He received IV steroids, dexamethasone for around a week. And his creatinine during this particular admission was around 0.9 milligram. And he made a successful recovery and was discharged. But lo and behold, in the month of June 2021, he presented again to Amri with bilateral flank pain and decrease in his urine output. And he also had acute pulmonary edema during this time. He was found to have a poor ejection fraction of around 30. He was also detected to have severe renal azotemia with a creatinine of around 5.8 at presentation, which progressed further, and he ended up needing dialysis. So he was worked up for the kidney failure. He underwent a CT KUB, which showed that he had bilateral gross hydronephrosis. His urine culture details during that admission were not available in the discharge summary. He underwent a cystoscopy and a bilateral and RGP, which showed that he had bilateral ureteric stricture. It didn't make much meaning to us as to why he had bilateral ureteric stricture in the notings, because he had never had any other prior instrumentation or anything, but this is what was noted in the file. He underwent bilateral DJ stenting in June and he received antibiotics. He tells us that he had good urine output. He was still making around a liter of urine, but there was no improvement in his renal function. He was being checked periodically and he was told that the creatinine still remains between 8 and 9, and he was continued on dialysis. So between June and August 2021, he remained dialysis dependent. That's more than 3 months. And finally, in August 2021, his doctors over there decided to do a biopsy to identify why he is not recovering. The biopsy showed some tubulointerstitial nephritis and AT, and that was the file noting. Details of any further treatment is not available, but based upon what the patient says, he did not receive anything extra. He was continued to be dialysis dependent with a urine output of a liter. Then in month of September, his stents were removed, and as soon as his stents were removed, he became anuric. So the doctors there again did a left ureteric stenting, but when they tried on the right side, the right could not be stented. They said it was a tight stricture. So he was offered a right PCN, and since he was not happy there, he then traveled to CMC Vellore. In CMC Vellore, again, an attempt at right retrograde stenting was attempted, but again was unsuccessful. And here he agreed and a right PCN was performed. So he had around 300 ml of urine coming from the right PCN, around a liter coming per urethra. But despite this, he had no renal recovery. He moved back to Bangalore because this was his place of work. And by December, he was in some of the affiliate hospitals across Bangalore. And one of these hospitals again attempted an antegrade stenting through the PCN, but was again unsuccessful. So he continued to remain dialysis dependent, doing dialysis 3 times a week. And during one of these dialysis episodes, he also suffered a cardiac arrest, needing a brief episode of resuscitation. So finally, he comes to us in the month of March 2022, that is almost a year after the onset of his problem, with the desire that he wants a renal transplant. He's fed up with what is happening with him. So this was the baseline CTKV that we did when he presented to us. We can see that on the right side, he has a PCN in place. On the left side, he has a ureteric stent. There was mild to moderate perinephric stranding. There was no thickening of the Gerota's fascia. There were no perinephric collections. There was moderate hydronephrosis despite the stent being there on the left side. So this was the reports as mentioned. There was a PCN on the left, PCN on the right, DJ stent on the left with some perinephric stranding. So by March 2022, the cause of his ureteric stricture was still not clear to us. We sent a couple of urine for AFPs, which came negative, urine gene expert negative, cultures that we did were negative. When he came to us, he wasn't spiking any fever. We did a DTPA scan. He had very poor function of his right kidney, that is the kidney that had the PCN. And since he was very keen on a transplant, he didn't want any further investigation into his old kidneys. We decided that we would just do a nephrectomy on the right side. And since there was moderate hydronephrosis on the left side, we thought we'd just do a stent exchange on the left side. And that was what was done. So in the month of March, we did a right open nephrectomy. And this is where the picture changes. So this is a low magnification of an artery. We're focusing mainly on an artery. And you can see that there were broad aseptate hyphae with invasion into the anterior, into the arterial wall, both on all different stains, that is the HNE, the PAS, as well as the silver stain. So the the biopsy also showed a few granulomas. Gene expert on the biopsy showed was negative for TB-PCR. So histopathology of the right kidney, multiple fungal hyphae, which are broad aseptate with obtuse angle branching, and numerous well-formed granulomas with central areas of necrosis. Morphological features suggestive of mucormycosis. So this was something that we were not expecting and took us by surprise. So after this, we started him on liposomal amphotericin, which he took for almost 3 weeks. And following this, we switched him over to oral posaconazole, which we gave him for 3 months. But no renal recovery. He still remained dialysis dependent. He had come to us with a temporary line, which we converted into a perm cath, anticipating long-term dialysis. But the story was not over here. Despite he being on dialysis, he continued to be malnourished, losing weight, becoming cachectic, having intermittent left flank pain. He had refractory anemia, needing transfusions occasionally. And he was very keen that he wanted a transplant. So we did a PET scan at this point in time because we were not expecting isolated renal mucormycosis. We were basically looking at whether there's any dissemination from somewhere else. And we didn't find any other source. There was only increased metabolic activity in the left renal fossa, but no other evidence of disseminated disease. We also did an HRCT to look for whether there is any coexisting pulmonary mucormycosis, but basically we didn't find anything. We found post-COVID changes. We found some bronchiectasis changes, but apart from this, nothing else was found. And finally, we ended up deciding that we were not going to transplant him, leaving one kidney back, given the background that the other kidney had mucormycosis. So we did a left kidney nephrectomy in the month of June. And the biopsy from the left kidney again, as you can see, again showed fungal filaments with broad septate hyphae and multiple granulomas which were necrotizing. So again, the diagnosis on the left kidney was also mucormycosis with granulomatous inflammation. So now he was anephric and he was on dialysis with us. He had a left IG, but the left IG was giving us flow issues. He had one episode of CRBSI, and to his bad luck, during one of the dialysis sessions, he reacted badly to optineuron injection, went into a brief arrest, and again needed CPR. Another issue that we faced was one of these admissions. He was receiving antibiotics through a central line on the right side, and he ended up clotting off his entire right upper lip, thrombosis of the basilic, axillary, subclavian, and interjugular vein. So again, probably line-induced, but again needed management with anticoagulation. Just when we thought we'll create a fistula and try to get rid of all these perm caths, he again had an episode of pulmonary edema. His ejection fraction was 27%. He was found to have a large apical clot, and then again he needed anticoagulation with rivaroxaban. As a part of his transplant workup, an angiogram was done, and angiogram was found to be normal. So his transplant, his prospective donor was his mother-in-law. It was an ABO-compatible donor, but when we did the pre-transplant evaluation, we found that he was marginally sensitized. So his CDC came negative. We do a DSA lysate, which came negative for class 1, but borderline positive for class 2. So since he had received blood transfusions and he had sensitizing events, we thought we'll do a full HLA typing of the donor and look at the single antigen bead. And in this, we found that he had donor-specific antibodies, class 1, in titers, MFIs of around 1,500 and 2,500 range. Class 2 came negative on the single antigen bead. So just to summarize the whole sequence of events, the story began in April when he was diagnosed with COVID. By June, he was found to have renal dysfunction and initiated on dialysis and found to have bilateral HUN needing stenting. By March to June, he underwent right nephrectomy, and by June, he underwent his left nephrectomy, and both of them showed isolated renal mucormycosis. His dialysis issues, multiple. He had cardiac arrest, he had a poor heart, he had central vein thrombosis, he had CRBSI, he needed central vein plasty for central vein stenosis, and he had sperm cath flow issues needing fibrin sheath lysis as well as sperm cath exchange. And finally, when it came to transplant, he also found that he was marginally sensitized. So issues here, access issues. He was just not doing well on dialysis. He had a poor heart, so is he transplantable or no? These were the thoughts that were going to our mind. He's becoming malnourished as we continue him on dialysis. Mucor at the back of our mind was always there. Is there any element of a disseminated disease? And obviously the sensitization issues. So these were issues that we were dealing with. So we thought we'll cool him off, wait for some time, and reassess him periodically to see whether anything else happens. And by around March of 2023, we found that he was reasonably stable enough to go to the transplant. So his mother-in-law was his prospective donor. It was a blood group compatible transplant. CMV status was D plus R plus. And since there was no HLA match between the two, we decided to give him low-dose ATG induction. Transplant details, immunologically, as I said, historic cross-match, he had an SAB, but at the time of transplant, his CDC, DSA, as well as SAB turned out negative, so we didn't have to do any kind of desensitization in him. We decided to go ahead with the transplant. The transplant was unsuccessful by the grace of God. He had good graft function. He achieved a nadir creatinine of around 1.4, and he has now almost a year of follow-up, and he's still doing well with a creatinine of 1.5. He's gained weight, he's nutritionally much better, and his heart is also improved to an ejection fraction of near 48%. So this particular case was written up by our postgraduates as isolated renal mucormycosis post-COVID. This was pre-transplant that we wrote it up. And just a review of literature, as since this is a case of an isolated renal mucormycosis, there's a very good review article that you can read up on by Dr. Arvind Chakrabarti, who's the father figure of mycology probably in this part of the world. So the exact incidence, according to him, is prevalence of mucormycosis is more than 70 times higher in India compared to what is the global data. And isolated renal mucormycosis is in an immunocompetent host is a unique entity that is being reported from India. So we know that mucormycosis basically are of 5 different types: rhinocerebral, cutaneous, pulmonary, renal, gastrointestinal, and disseminated forms. And the prevalences of them are in the same order. The rhino-orbital mucor being most commonest, then we have cutaneous and pulmonary. Renal is less common, and disseminated and gastrointestinal even less common. So if you look at the risk factors, for diabetic patients, you have a big spike as far as rhino-orbital mucormycosis is concerned. Pulmonary, you have a big spike as far as solid organ transplants are concerned. Cutaneous, a big spike whenever there is a trauma. And renal isolated mucormycosis, there seems to be a big spike in immunocompetent patients. Not talking about immunocompromised patients, immunocompetent patients. So that's something that was revealing something that I did not know at that point in time. And if you look at the mortality rates of all kinds of clinical forms of mucormycosis, you can see that in the yellow, isolated renal limited mucormycosis, the mortality rates quoted by Dr. Chakrabarti et al. Was 60%, by Prakash et al. 52%, and Patel et al. Was almost 50%. So mortality ranging between 40 to 70% is what is being quoted in medical literature. And look at the response to treatment. Amphotericin plus surgery seems to be performing the best compared to amphotericin alone or surgery alone. So significant mortality as well as morbidity as elaborated in these slides. And this was one of the largest case series published by PGI Chandigarh of around 15 cases, and 15 cases over 5 years of isolated mucormycosis. And the mortality rate in that series was around 40%. And there again, isolated renal mucormycosis, these were in immunocompetent hosts, further elaborating the problem. And as you can see in these 15 cases, whenever they were bilateral, out of the 4 bilateral cases that they had, almost 3 of them died. Only 1 was alive to tell the story. So it's a bad disease, especially when it is bilateral. So they've come up with an algorithm wherein they say that whenever you have a non-resolving pyelonephritis on intravenous antibiotics, then you perform a contrast enhanced CT to look for features suggestive of mucor. And if the kidney is not enhancing, then start amphotericin B empirically and then do an emergency nephrectomy. If the kidney is showing patchy or incomplete enhancement, then consider a biopsy. And if it's positive for fungus, start amphotericin and assess response. If it's negative for fungus, then treat as pyelonephritis. So this is pretty much standard what we routinely do. In this particular case, he had a biopsy, but did not reveal fungus, at least based on the report. And it was only after we did the nephrectomy that we identified mucormycosis. So some of the take-home points: the prevalence of mucormycosis is way above what we think it is, more than 70 times higher than the global data. 14 cases versus 0.2 cases per lakh population. Renal mucormycosis is commonly seen as a part of disseminated mucormycosis, but isolated renal mucormycosis is rare and seen in around 1 to 9%. Diabetes seems to be the most common risk factor, followed by solid organ transplantation and malignancies. The solid organ transplant is a risk factor contributing to around 2 to 10% of all the mucormycosis that we see. Rhino-orbital mucormycosis is the most commonest form globally, but in solid organ transplantation, pulmonary mucormycosis is more common. And in India, around 3 to 25% of all the mucormycosis are recorded from immunocompetent hosts. And isolated renal mucormycosis is a unique entity that we see in our country in immunocompetent patients. And in different case series reported across India, the 33 to 100% of all the cases were immunocompetent hosts. Patients present with a classical fever, flank pain, hematuria, dysuria, acute kidney injury. Many a times they are culture negative and refractory to antibiotics. A contrast enhanced scan or an ultrasound may help in the diagnosis. An enlarged kidney with or without hypodensities, perinephric standing, thickened Gerota's fascia, bulky psoas, reactive pleural effusions. These are classical imaging findings that is also seen in this group of patients. And the mortality range is pretty high. For rhinocerebral, it's around 30 to 50, and for isolated renal, it is around 40 to 70%. So with that, I conclude my talk and that we go for questions.
Thanks, Rogan. Can you unshare so that we can have a discussion? Sir, over to you, sir. Ramalingam, sir. Ma'am?
Dr. Abhinami?
Yes, sir. I'm here, sir. So
What's
you
your
can go ahead
impression?
first, sir.
What's your impression? Please go ahead then.
Sir, I think the instrumentation was a problem. I don't think this mucormycosis is related to COVID.
Yeah.
The longest period reported is, I think, 4 to 6 months, not longer than that. This guy had COVID in April and then he developed mucor in March 22. So I don't think he was going around with mucor also for a long time. That's not possible. And it didn't disseminate. So in this particular patient, I think instrumentation was the issue. And I would have looked for endocarditis, endophthalmitis. Again, I'm surprised about 2 months gap between the first mucor and the second mucor and the other kidney. So, Dr. Ron, did you find any CT changes in the other kidney when you did the first nephrectomy?
So, your point is well taken, ma'am. 2 questions that never got answered was the illness began in the month of April and there was something that produced both kidneys to shut down. At that point in time, he didn't have an instrumentation. So there was something that predisposed him to go into acute kidney injury when the whole illness began, which they could never conclude, basically. Kidney never opened up. There was something that produced bilateral hydroerythronephrosis, which needed them to be stenting. Now, whether subsequently during instrumentation, mucor was some seeding did take place or no is difficult to say, but there was something that began the whole story. That much is certain. Second is, when we did the first nephrectomy, the CT, we based on the CT. We didn't do a contra CT, which I think is one of the limitations. We did a plain CT because when he first came to us, we were still debating whether, since he had urine output, we were not really sure whether we need to go with a contra CT, which on hindsight was a mistake from our side. But DTPA scan did show poor uptake of that kidney. And since he was fed up and he just wanted to get transplanted somehow, I think the rush at that point was that we wanted to somehow knock off the right kidney, and we thought that we'll manage with the left kidney and then do the transplant. But when it got mucor, that was when the surprise came. The surprising thing was also that he took some time for him to get fit for undergoing another nephrectomy. That's the reason why there was a delay of around 2 to 3 months. And during that interim time, he was on treatment for mucormycosis, but the disease still remained indolent. I would accept that point. It was not like he was disseminating it to other areas of the body. His echos were done periodically. He never had any valve involvement at any point in time. He never developed any ophthalmitis at any point in time. So he remained indolent during those 2 to 3 months. Whether it was suppressed by treatment or no is difficult to say, but that was the reason for the delay.
I will agree with Dr. Abhirami. Rohan, it is too long a period for somebody to have mucor from COVID and remain without major life-threatening complications. At the same time, there is no explanation for what happened in the kidney in the form of hydronephrosis and ureteric strictures. And it is very difficult to say that that was not a mucor, but at the same time, a mucor for about 6 months would have killed somebody.
True.
And the point is that he must have had urine examination, urine cultures, and ultrasounds. Sometimes ultrasounds show classical appearances in which the radiologists are able to pick up something like lack of echogenicity in areas, and they suspect mass lesions, mucors, and it is possible that the mucor in the other kidney was suppressed from becoming very active by the treatment you gave. But at the same time, whether the whole thing right from the beginning was mucor, or whether the mucor was introduced during a procedure, it is very difficult to conclude. What do you all feel? What do you feel? Rajan, what do you feel?
Ma'am, please go ahead, ma'am.
And the first biopsy did not show any fungus. They did do a biopsy right away in August.
Yeah. That showed only an interstitial nephritis.
Was he given steroids at that time, Dr. Rohan, for interstitial nephritis?
His steroids were only at the initial part during COVID. After that, he hasn't received any steroids.
So he must have got if the biopsy had been, I'm sure they won't miss a mucor in the biopsy. So the mucor must have come only after the biopsy. And that must have been due to some instrumentation. So we would take it that it is instrumentation-induced renal mucors, which were suppressed on one side by the treatment, removed on the other side, and he was managed by you well now till the transplant. So what do you feel, Vel? What do you feel, Rajan?
Before that, we will take chat, sir. Chat, they were a very relevant question they asked, sir.
Yeah.
Rohanji, what made you to do a nephrectomy?
Yeah, first time. Why did you do a nephrectomy? I also wanted to ask him.
The one chat box, there is the query, Rohanji.
So the issue was that he had visited so many hospitals and he's finally stuck with this PCN, which is not draining, which they can't remove at the same time. They're not able to introduce a step.
But
so he was not. he was not keen on doing any further intervention. Probably he had enough visiting multiple hospitals. So he basically came to us with the intention that I want a transplant and I wanted to get rid of this kidney. That was the basic. He did not give us any scope for further evaluation as to what. We could just do basic evaluation, and then his request to the urologist was, please remove this kidney and get me transplant. So
Why did he think that kidney was preventing him from getting a transplant? I thought he had some fever around that time, and that nephrectomy was done for sepsis.
No, when the first kidney was removed, he was reasonably. He did not have fever. He didn't present to us with fever. He just came with a tube which was not making any urine. The fact that he was not able to be stented from below, couldn't be stented from above. There was a PCN which was there, which was still making some urine, and no one would transplant him with those kidneys sitting there. So we felt that we were not comfortable in transplanting him with an infected kidney. We did not know it was mucor at that point in time, but we still felt that he has had multiple urological interventions and he has come to us. We were not comfortable leaving that kidney behind before we do a transplant. So we decided only to remove one kidney out so that the other kidney we can manage with the stent and pull out the stent at a later date and then do the transplant. But it ended up.
It is very rare of late for people to do nephrectomy to make somebody fit for a transplant, isn't it? What do you all feel? Just to.
And if the output is very low, you could have just pulled out the PCN. It's not like you have to remove the kidney.
And somebody shared, Dr. Vilas has shared one message from his own experience. I think we got it from peculiar cases. He had a similar mucormycosis, and a treatment for 4 weeks failed. Then nephrectomy, vascular thrombosis, still fungus is present, and that's what his personal experience. And somebody asked, when you had a bilateral mucor, did you find any bladder involvement, Rohiji?
No, we did not find any bladder.
Okay, that's what the other question. Sambat sir was asking, would you give a posaconazole for some more time to?
People think it must be given for a very long time. Sambat is right, and there are literature saying that you give it lifelong. I do not know whether anybody can take it lifelong. What do you feel, Sampat?
Sambat sir, are you around here? So Rohanji, is on any kind of such therapy, posaconazole or any we want nothing, no, right? You just since you got it up for both kidneys, you are quite confident about.
No, we once we knocked out both the kidneys, and then once we had repeat scans which showed no uptake was there anywhere else, that we did not further give antifungus.
They waited almost a year, so I think we were sure the fungus is out.
We waited for almost a year.
Yeah, very true, sir. Very true. So, Sambat sir, are you around here? You can clarify your doubts, sir. You said about to be given, sir. Please, sir. Go ahead, sir.
No, nothing.
Nothing, sir. Okay. Rohanji, I found one of the very interesting histology finding. It's a granulomatous lesion, right?
True.
That's that's what we read in textbook. And fungus can produce rarely granulomatous lesion. And you said, and in the report we saw the palisade of macrophage, which is giant cells, almost like tuberculosis.
Yes, the description is almost like tuberculosis, except that there are fungal hyphae.
That's a very rarely mucor can present with the granulomatous. That's a point, a very important point here.
Yes.
Very nice. We'll please be here, and some questions that we have in the end we can answer. And I think it's a good presentation. At least I think Angel has sent a message to remove the both kidneys. Had we been in your situation, I think we would not have gone for this kind of this is something very unique, and we have to keep in mind at least.
Are the ureters there, and are you remove the ureters?
Ureters as well, sir. Nephrouretectomy.
Nephrouretectomy. Okay, so you cleared both. You knocked out the entire
urinary system except the bladder.
So quite interesting, we'll keep in mind actually. It's a good presentation. Thanks. Very short and sweet and given the right message. Gauri, can you share your slide?
Yes, sir.
Yeah, please go ahead.
Hope my slides are visible.
Yeah, yes, visible, Gauri Sangha. Your voice is also clear. Please go ahead.
Yes. Good evening, everyone. Today we'll be discussing post-transplant photocytopathy. I am Dr. Gauri Shankar, representing Meenakshi Mission, Associate Consultant in the Department of Nephrology. With no further delay, moving on to the case, a 10-year-old man presented to us in 2011 with bilateral pedal edema and some foaminess in the urine, which on evaluation was found to have nephrotic syndrome. He was initially started on steroids at 1 mg per kg. He was found to respond to the same. However, on decreasing the dose, he had a relapse on high threshold of steroids of more than 0.5 mg per kg. Further, he was subjected to renal biopsy for the same, which was reported as focal segmental glomerulosclerosis, not otherwise specified. So for the purview of same, he was given tacrolimus followed by mycophenolate mofetil. However, the disease relentlessly progressed and progressed to CKD ESRD within a span of 2 years. In 2013, he was duly initiated on hemodialysis. However, he was not maintaining well on hemodialysis and later shifted to CAPD. He was worked up for transplant with father as a donor with no known comorbid illness. It was a standard immunological test with HLA haplomatch. He was induced with steroids and was given standard triple immunosuppression. And he was doing well with an added creatinine of 0.9 milligram per deciliter with no relapse of proteinuria post-transplant until 2023. By 2023, he had a herpes infection, which was duly treated, and during that point of time, MMF dose was reduced. Further, in September 2023, he went to Kerala, where he took some food, and following that, he had nausea and vomiting, and he also developed transaminitis, which was duly evaluated and found to have acute viral hepatitis A. Following that, MMF dose was reduced. Within a span of 1 month, he started having bilateral pedal edema in November 2023. So, what are we dealing with right now? So, in our minds, we had a very difficult problem of dealing with a post-transplant FSGS because his pre-transplant kidney was more suggestive of a malignant FSGS pattern. Are we dealing with a minimal change disease, which was possibly a viral trigger? Or are we dealing with rejection? However, it is very less likely on the cards because the creatinine ratio was only 0.9 to 1.2. Or are we dealing with very rare cases of some de novo GN like membranous GN, MPGN, or a very rare case of PGN-MID? So we went ahead with the allograft biopsy, which was reported as minimal change pattern, and a possibility of an underrepresented FSGS was also considered. Hence, he was duly started on plasmapheresis sessions. We gave him 3 sessions of plasmapheresis and 1 dose of rituximab at 375 mg per meter square in February 2024, January to February 2024. And he is currently maintaining well. He has achieved partial remission in May 2024. These are the histopathology images. On your right side, you can see the silver stain as well as the PAR stain showing normal glomerular morphology and a back-to-back tubular appearance with no interstitial involvement or tubulitis or glomerulitis. No PTC is visible. This is the lower bar view showing no significant HEFTA in the sample biopsy with 5 glomeruli being present. Courtesy Professor Anila Abraham, ma'am of the Indian Heart Society. The laboratory parameters trend, you can see that September 2023, when he had the acute viral hepatitis E event, his serum albumin was 4 and urine routine microscopy revealed a nil dipstick urine protein. However, within a month span of time, his albumin dipped to a nadir value of 1.8 with proteinuria racing up to 9.5 gram per gram in urine PCR. And it peaked to a value of around 16.2. Following therapy, it gradually reduced, and currently, by April 2014, he's maintaining a urine PCR of 0.8 grams per gram, and his serum albumin has resolved to more than 3.5, which is 3.8 right now. So currently, he has achieved a partial remission by definition. His edema has settled. He had great emotional distress. However, he has started going back to college now. We have received the EM, which is suggestive of widespread diffuse food process effacement of 80%. However, there were no electron dense and viral particles noted in the EM. So at this point of time, we had doubt whether we are dealing with an FSGS post-transplant or an MCD pattern which is being shown in the biopsy. So factors trapping FSGS are the pre-transplant native kidney disease, which has been reported as FSGS, not otherwise specified, and a malignant course, and the presence of massive abrupt proteinuria. However, the factors against FSGS are biopsy, which is not suggestive, even though we can have a minimal change pattern in early onset FSGS or an unrepresented FSGS can also have such patterns. And the very late onset of FSGS at nearly 7 years post-transplant, even though there are case reports of around 8 to 10 years post-transplant of FSGS recurrence, a very effective and a brisk response to immunosuppressive therapy, which is very rare in case of FSGS. However, factors favoring MCD or massive proteinuria, biopsy suggestive of MCD pattern, and an early and brisk response to immunosuppressive therapy. Factor which is against MCD is a pre-transplant disease of FSGS. However, a de novo MCD can be proven. So hence the unit final diagnosis is a post-live renal related allograft transplant with a basic disease of biopsy-proven FSGS with donor being father, who is a haplomatch for the child. Use of steroids was on immunosuppressive. He had a hepatitis A virus in September 2023, following which he recovered without any acute liver failure or severe acute hepatitis. Post-transplant podocytopathy, probably a de novo MCD versus an FSGS picture, status post 3 sessions of plasmapheresis and 1 dose of rituximab at 375 mg per meter square, currently maintaining a partial remission. Moving on to the discussion, we all know that all forms of primary GN can recur post-transplant, and it is one of the 4th most common cause of graft loss following rejection, death with a functioning graft, and a chronic TG. We all also know that around one-fifth of the kidney allografts are lost due to the recurrent GN, either due to recurrent or a presumed de novo GN. And recurrence of GN carries a risk of twice succumbing to overall and death-censored allograft loss compared to a non-recurrent GN. So in this respect, protocol biopsies may prove to be useful. However, the therapeutic significance of these biopsies is still undiscernible. So in the ANS data registry, which has been put forth by Penelope group, they have assessed the risk factors, and it was seen that the risk, there is a 2% reduction in the risk of the disease recurrence, the glomerular nephritis disease recurrence, for every year increase in the age of transplantation. And steroid use at baseline was particularly protective against IgA nephropathy. They've also found the fact that a longer total ischemia time was protective against the recurrence of glomerulonephritis disease. However, they weren't able to provide any logical reasoning for the same. In the same paper, they also went on to see that when the glomerular disease have recurred, of all the glomerular disease, MPGN has got the worst graft survival. At 5 years, the graft survival is only 30%, in comparison to around 55 to 59% of all other GNs, namely membranous, FSGS, and IgA nephropathy. So whenever we are dealing with a post-transplant proteinuria, we should look for false positives. And when proteinuria is not confirmed, we should rule out the false positive causes. And when it has been confirmed, we should measure the proteinuria. If it is less than 500 milligrams, we should monitor the proteinuria daily. If there is a raise in proteinuria, or if the initial proteinuria value is more than 1 gram, we may consider biopsy. Having said that, there is no straight and hard and fast rule for biopsying these patients. At this juncture, we should also consider the tubular as well as the glomerular causes. We all know that ischemia reperfusion injury, ATN, and acute rejection are all the tubular causes. And we have the glomerular causes being represented by recurrent and de novo GN, transplant glomerulopathy, drugs, and viral diseases. Much more important than proteinuria is the time frame of proteinuria occurring post-transplant. It was seen in one of the largest cohort done by Maislak et al. That proteinuria reduced to insignificant levels by a month post-transplant. So whenever we are seeing any significant proteinuria by a month post-transplant or an increasing proteinuria post 1 month of transplant, that has to be considered significant. And it has been even proven that for each 1 gram per day increase in proteinuria above a normal value, there is a risk of death increasing by 16%. We can also see from the bar diagrams which has been provided that for the increasing range of proteinuria, there is geometric increase in the hazard ratio of succumbing to allograft loss. So which gave way for the KDIGO to put forth the guideline, saying that in a case of pre-transplant FSGS, we should monitor daily for the first week post-transplant and weekly for a month, and then every quarterly for 1 year, and then annually. For all other diseases, once in the first month, and then quarterly in the first year, and then annually. So moving on to FSGS, we know that only primary form of FSGS recurs, and 30% of the cases generally recurs, which is associated with poor survival. We have 2 patterns of recurrence, either early or a late recurrence. Early recurrence is usually associated with abrupt onset of proteinuria and a good response to immunosuppressive therapy. However, the late recurrence occurs insidiously and responds less well to immunosuppressive medications. We also know for the fact that genetic forms of FSGS, high risk ApoL1 genotype in the recipients, they carry very low risk of recurrence, except for podocyte mutations and specific TRPC6 mutations. So the risk factors, as we all know, whenever we have a younger patient at the onset of nephrotic syndrome, early onset of FSGS, those who are undergoing pre-transplant bilateral nephrectomies, progression to ESRD within 3 years of disease onset, with a higher level of proteinuria presenting pre-transplant, and a history of recurrence in the previous allografts. And it has been seen that the recurrence risk increases up to 100% whenever somebody is going for the third transplant, and a related young donors with NPHS2 mutations. However, there is no effect on the histologic subtype variant of FSGS. And we all know for the pathophysiological factors, the circulating permeability factor, namely CTCL1, SUCAR, and the newly hypothesized factors ApoA1, CD40, and the anti-nephrin antibodies, which has been proven in recent trials. Treatment, anti-CD20 antibodies does reduce proteinuria. It has been shown that they may act on the glomerular podocyte through the specific sphingomyelin pathway, modifying the actin cytoskeleton. Pheresis is used in some patients. It presumably acts by removing the circulating factors. However, the role of pre or post-transplant plasmapheresis in a case of pre-transplant FSGS is still unestablished. French people generally use IV cyclosporin. However, there are issues with continuous infusion and nephrotoxicity. However, it is not very famous in other parts of the world. People generally use high-dose steroids. In non-responders to all these measures, people have resorted to LDL apheresis, ACTH gel application, and in specific CDC1 positive cases, people have even used the CTLA4 immunoglobulin fusion protein, abatacept. So the review says that around 60% of the children, around a half of adults with recurrent FSGS generally goes for a composite CRPR with plasmapheresis and rituximab, and maintaining a high dose of CNI. However, further RCTs are needed to define optimal therapeutic regimens in this. The largest cohort of post-transplant glomerular disease looked into the risk factors of recurrence of FSGS. It is told that presence of old age, white race, and bilateral native kidney nephrectomies are all the risk factors. And recurrent FSGS was present in 32% of the cases, and of this, 39% went on for graft loss within a median period of 5 years. And the response to treatment was seen in around 57% of the patients. So moving to de novo MCD, it's very rare. Exact incidence or prevalence was not known. It was restricted only to case reports. The possible pathophysiological basis is likely T cell dysfunction, leading on to altered cytokines and altered PERM selectivity of the glomerular capillaries, thereby explaining the risk response to steroids. So this paper by Truong et al. Basically looked at the case review as well as the literature review of around 14 cases of MCD, de novo MCD. And he went on to see that around 60% of the patients who had de novo MCD had undergone live renal allograft transplant. And most of the cases recurred shortly after transplantation. And with the application of steroids and the standard non-immunosuppressive antiproteinuric therapy like ACRBs and antilipidemic agents, remission was duly achieved in more than 95% of the cases. Having said all this, can de novo MCD present very late post-transplant? Yes, there are some case reports of late de novo MCD being present at 7 to 8 years post-transplant. This case report has shed light on the same. So moving on to further, are we dealing with some anti-nephrin antibodies? Even though the IF of this picture didn't show any IgG dusting, falling short of serological marker, it is very difficult to tell. The recent landmark paper published in NEJM has went on to say that around 2/3 of active MCD pre-treatment will have, and around 90% of idiopathic nephrotic syndrome will have anti-nephrin antibodies. There is also a possibility that Flex could have removed these anti-nephrin antibodies, hastening the recovery of this MCD. Is still to be answered. Further unwithering the knots which has been present in the case, can this all be triggered by hepatitis A virus? I have not found any case of hepatitis A virus triggering MCD, and it is very difficult to prove by biopsy. However, there are cases of hepatitis A virus leading on to focal segmental glomerulosclerosis proven by temporal associations. So the take-home messages from this presentation is that any post-transplant proteinuria must be duly evaluated, and the increasing amount of proteinuria is directly proportional to a long-term graft outcome. Protocol biopsies at this juncture might be proven to be beneficial. However, the therapeutic significance has to be proven in large-scale trials. The most important fact is pre-transplant counseling on disease recurrence and early identification, which are key factors in managing post-transplant porocytopathy. Still unanswered question, can this be virus triggered? Is there any way to prove or disprove the same? Is there any role of anti-nephrin antibodies in risk assessment post-transplant in such cases? So, thank you. And I would like to thank the organizers for this opportunity, especially Dr. Vel sir and Dr. Rajan sir. And I would like to thank Professor Sampath Kumar sir for giving me the opportunity to present in this forum. Thank you, everyone.
Thanks, Gauri. Can you stop sharing?
Yeah.
Very interesting one. Very interesting. And more than your your presentation slides were so animated, so nice.
Correct. A very new
Very
form.
unique. Very
New
unique.
form.
You can teach us on that aspect too.
Just want to ask Gauri one thing, Vel.
Yes, sir.
Can I ask one doubt to Gauri?
Yes,
Yes, sir.
yes, sir. Please, ma'am, and you can take over, sir. Another 15 minutes we have, and if it's
Okay, I'll just ask my major doubt.
Okay.
Gauri, why did you do plasmapheresis?
Sir, as a pre-transplant biopsy was suggestive of FSGS NOS, and his pre-transplant course was like a malignant FSGS. In 2011, he had the disease onset, and within 2 years span of time, he was non-responsive to most of the therapies, and he went on for CKD ESRT. So, hence, a possibility of a post-transplant FSGS recurrence was
To
considered.
make it short, you did it because you thought it was FSGS unrepresented in the biopsy.
Yes, sir.
Abhirami, what do you feel about it? I think I would have.
Even for FSGS, which is recurring this late, I would not have jumped into Plex. I would have increased the steroid dose because initially he was steroid responsive. Then I would have gone the Ritex route. And I also was wondering, pre-transplant, did he get any rituximab at all? You talked about steroids, then TAC and MMF.
No, ma'am. Pre-transplant rituximab was not given in this case.
Because he got transplanted in 17, so 15, 16 and all, we had rituximab. Okay. Even for FSGS, I don't think there is enough data for Plex if the FSGS recurrence occurs late. Right?
What do you all feel? I would have treated him with a higher dose of steroid, taking it that it is a very rare patient of minimal change nephropathy occurring after transplant. In my own experience, I have not seen any one. At the same time, there are reports as also indicated by Gauri, and I would have treated him with higher doses of steroid and seen what happens and then taken a decision. What do you all feel? Anybody can please?
I will take the devil's advocate.
Yes,
I
Sampath.
feel that this case opens up a new avenue for management of MCN with plasmapheresis. Very short courses of plasmapheresis, 3 doses, anti-nephrin antibodies are now very much being escalated as the important cause of minimal change. Whether a very short course of whether a very short course of plasmapheresis is going to give us the long-term excellent benefits of rather than having steroids for a long time. This is a thinking which I had after I saw the dramatic response after 3 courses of plasmapheresis. He was having massive proteinuria, he was edematous, his albumin was dipping, and I was convinced that it was recurrent FSGS and then went ahead with the plasmapheresis. But this was a real surprise. So this opens up another avenue whether for MCN we should start doing plasmapheresis. You may all lampoon me, but this is what I want to say.
I think you having seen the patient Sampath will be definitely a good recommender for this form of treatment. Yes. I really know that we cannot comment on what you have seen and what
Yes,
you
sir.
have felt, and it is
Yes, sir.
very genuine.
Yeah.
What
Yeah, genuine
your
doubt I
feelings
have.
and your
Yeah.
recommendations are genuine.
Yes.
We must definitely consider. And after that, was he on a higher dose of steroid, or he was not
No,
on
sir.
a higher steroid?
No, he's Gauri, what is his proteinuria now?
His proteinuria now is 0.8 grams, sir. His albumin is
That is-
repleted to 3.8. He during the session of plasmapheresis, he was given short course of steroids and rapid taper of steroids were done. He's currently on 5 milligram of isodose.
5 milligram only. No, he has made. I never expected such a dramatic recovery, and I was thinking that we are going to lose the graft, and so this has come as a real surprise for me. This is why I am hypothesizing. Yes.
Gauri, do you expect the MCN, as you said in your talk, MCN may change to FSGS in future? Do you have a plan of any biopsy every 6 months?
No, if the proteinuria increases, then we will definitely
You will do
look into that. Yeah.
Okay.
Some people think it's a continuous disease.
Yeah.
I think we
And
can
if antinephrin antibodies are going to be available, probably we may use it. A hindsight.
Pardon? Sorry, I didn't hear properly. What is that?
If antinephrin antibodies are going to be available in near future, probably we may use it.
For a testing, there are reports, but they're not very specific, or not all MCN patients have antinephrin antibodies. That's what my understanding is. You have false negatives, isn't it?
Yes, sir. If it turns out to be positive, it may be used for prognostication purpose.
False
And for
negatives are nearly 50%. That's what I understand. So antinephrin antibodies will not replace biopsies.
Okay, and let's now.
Yeah. Now the other thing is, now talking about the management of the post-transplant FSGS, it is very good to listen, very good to get information from papers and recommend managements. But from my own experience, in a busy nephrology practice, it is not easy many times to make a diagnosis of the primary disease. And apart from that, it is not also easy to go on following somebody's urine protein regularly, because there are difficulties, as well as apart from the difficulties, there are fallacies in urine PCR also. PCR is not a very well no, I won't say done. It is a test which can be falsely negative, falsely positive sometimes. So what I'm trying to tell you all is that even though I have knowledge of many things, I'm not able to put into practice the actual identification of the primary disease, actual follow-up of these patients after transplant, and I identify them only late. I do not know what your experience is. Abhirami, Rajan?
I get urine routines regularly, sir.
Sir, we do that, Abhirami, but we many times we do urine routine, but we don't have the primary diagnosis.
Oh, that is there, sir. That we follow over a period of time.
The primary diagnosis, Sampath, do you have a very well done primary diagnosis?
You mean to say the basic disease, sir?
Basic disease.
That is an issue,
getting diagnosis. Because it is useful.
Yeah, very, very unusual.
Yeah.
Yes, that is an issue. I am pro biopsy, but when we get patients only in ESRD, many a times we don't know. And that brings me to my question. Did we do a genetic study on this guy, pre-transplant? No.
No, ma'am. It was not.
And could this have responded to Ritex and not to Plex?
Sorry, ma'am. It was only one dose of 375 mg per meter square. So it is generally seen in the nephrotic cohorts of Indian standards that with one dose achieving a CD19 depletion is going to be very less likely. So I don't think that this is a straightforward response of rituximab. Probably a
What's the
cumulative
time frame
response
from the time of plex? When did the proteinuria start coming down? Time frame?
February it was started, ma'am. And after stopping the plex by 2 weeks time period, the proteinuria started dipping down. Even though he didn't achieve PR at that point of time, it reached a peak of 16 when we started plasmapheresis. And after finishing plasmapheresis and one dose of rituximab, it was 12 grams per gram.
But Gauri, one dose of rituximab, 375 milligram per square meter, does
Good dose.
lower the CD19 to almost nil in most of the patients. At the same time, I think, Abhirami, we must really give a lot of importance to the observation of Sampath of the major change happened after the plex. So on that observation, we must take it that the plex really helped him. That's what I feel. And it's definitely worth
Yes, sir.
on all our thing to remember that plex can remove a lot of substances.
Yes.
Okay. So I think we have come to an end. It's 9 o'clock. So Rohanji, I just have a basic question. What was the cumulative dose you used amphotericin in the beginning and the first nephrectomy after?
So we use liposomal amphotericin, so 3 to 5 milligram per kg.
What is the cumulative dose you used?
We gave around 3 to 5 milligram per kg daily for the full 3 weeks.
Oh, so approximately
It is liposomal.
Almost 3 grams you gave.
He would be around 50 kg, 3 milligram, 150 per day for around 3 weeks.
The second,
Can I interrupt Vel here?
Yes, sir.
We use the emulsion form and it is much cheaper. The dose is the same and the financial implication to the patient is much less. And we don't have large experience, but reading the literature, we find the results are more or less the same. And anybody has experience with the emulsion form?
What's the cost, sir?
Cost will be one vial of 50 milligram is 1,450 to the patient. Whereas if you take the
you mean lipid emulsion, right?
Lipid emulsion.
Right?
Yeah, lipid emulsion. Not the liposomal.
Right, sir.
There are 3 preparations. I'm sure all of you know. Only the regular, the other is liposomal. Third is the lipid emulsion. Lipid emulsion is only 1/4 of the liposomal cost.
Okay. So most of the time it is a reaction, sir. You give the febrile reaction body. That's the issue. I mean, comes everywhere.
Yeah. Apart from that, also the toxicity to the tubules. But in emulsion form, there is no reaction at all. We have used liposomal for a long time, but the patient's side they cannot afford after some time. So we have started using the emulsion, and it is very good, and there are no reactions. And
okay, fine, sir. So I think
Dr. Gauri, sorry, one last question.
Yes,
is
sir.
the patient now on ACE inhibitor or something like that?
Yeah, somebody asked in the chat.
Yes, ma'am.
Yeah, that is why I'm asking.
Patient is on maximum tolerated dose, a losartan around 50 mg per day, 50 mg dose, and is taking atorvastatin.
You are using Gauri Shankar?
Losartan around 50 mg of losartan is tolerated, sir. His blood pressure has dipped down to around 110. He is still 20 years. So we weren't able to hike up.
Presently, patient does not have edema and creatinine is normal. Hemodynamic, I mean, blood pressure is normal. Everything is perfect, right?
No edema, sir. Albumin is 3.8 and his UPCR is 0.8. Probably is achieving near complete remission.
Okay, what's the creatinine?
It's 0.9 milligram per day.
Okay. Okay, just keep following it and enlighten us when something goes wrong, so it will be a good lesson for us.
Yes, sir.
Yeah. Thanks, Gauri. Rogan Bhai, with this, thanks a lot for bringing this unique case from your repertoire. I think we've had, if you're not presented, we not have think about going for nephrectomy in extreme cases. Anyhow, but it's a different opinion, but still we learned a few points from your presentation.
Well, before you conclude, sorry, can I
Yes,
ask?
sir.
Can somebody tell me how to prevent the spread of mucar in a hospital when you have one mucar patient?
That's a difficult thing to.
Because you always have 3 or 4 transplant patients. And Sampath, what do you do, Sampath?
I only pray.
I do isolate them. Sir. You
Yeah,
don't
I
put them in
think-
the same transplant unit, right?
It's supposed to be
You do
aerosol,
isolate.
isn't it? Supposed to be aerosol. Is it, Rohan?
It is aerosol, sir. It
It is aerosol, but
Hmm.
the exact etiopathogenesis of renal is not very clear unless it's a part of a disseminated disease.
No, let us say that it is from blood, it is hematogenous spread. It is supposed to get into the vessels very quickly.
True.
Angio-invasive. And we always are scared to give patients with this disease in the hospital where there are other transplant patients. At the same time, we can't send them home also.
Okay, sir. Fine. Rohan,
Thank
did you
you.
do ureteric biopsy? Same section we have taken only our ureter also showed any kind of a mucar?
No, the ureter they have not reported as mucar. Although
Okay.
the ureter was a part of that, they have not reported mucar.
And okay, we learned a lot from you and Gauri, and the presentations was very lucid and the discussion was quite good. And I think we are ending with some kind of a take-home messages. So thanks, Rogan and Gauri Shankar, and ma'am and sir. Thank you for the for honoring us being here.
We must thank you all.
Thank you for the invitation. sir.
Rajan
And Sampath sir, thanks for
Thank you. Thank you.
nice
Thank you.
meeting all of you.
for young
Thank
buddies
you.
proving what sir.
Yeah. Yeah.
So he's carrying a wise shoulder, I mean head on his shoulder, right, all the time. No? It's good.
Yes.
Sampath can easily take a little rest.
Yes, sir.
Thank
With
all the
Gauri around.
participants. Without them, and this cannot be a very entertaining show. And we thank MQ Tangabandi and Karthik for being with us for the every program. Throughout the session, they sit and see to that everything going fine. And we look forward to having similar interesting section next month, first Saturday. Thank you, sir. Thank you, everyone. Thanks,
Thank you,
Gauri.
sir. Bye.
Thanks.
Thank you.
Thank you, Well.
Thank you, sir.
Thank you, Abhiram.
Thanks,
Thank you, sir. Thank you all.
Thank you, sir. Good night.
Thank you.
Yeah, perfect. Thanks, sir.